See everybody today. Recording is in progress. Okay, that's relatively new for us. We are recording these sessions and it's good to see everyone. We've got a special guest this morning as usual, but we have had a little hiatus with Friday Facts, and I just want to mention that our Friday Facts is continuing to progress on. And as you know, we like to interview somebody that is influential in the serious illness world somewhere around the world. And this morning we've got Kumar, and that's great. But sometimes we interview people from other places. So if you have somebody you would like us to feature on Friday Facts, please let Allison know and we'll schedule them in the future. So Allison, give us an update, please.
Hi, good morning, everyone, and happy Friday. I just have a couple of brief updates for you. The first update is our next coalition meeting is June 18th, again from our 10 to 1 o'clock time. More information to come as that date gets closer, but please mark that on your calendars and let me know if you have any questions there. The second update I'd like to share with you is CTAC has released a blog series on state coalition field reports. Those come out bi-monthly, that's my understanding. And the first one has been released and it featured the North Carolina Serious Illness Coalition within that blog post. That was in your member email, so feel free to read that and watch for those blogs as they are released. A couple of events coming up. There is a North Carolina Serious Illness website walkthrough coming up on Wednesday, June 9th. If you'd like to attend that to learn more about how our website is ran, different coalition questions, feel free to email me to register for that 15-minute event. That link can be found in your member email that went out this week. And then the last event I would like to share with you is I will share my screen. And there is a clinical practice forum on June 25th. This is about ethics. I would like to highlight that this features two of our coalition members, Deb Love and John Moskop. So please join that. The link to register is located on the flyer. The flyer is featured on our website, and I will also put it in the chat below so you can register during this call if you would like. Thank you.
Great, thank you, Allison. And as Karen is doing, please put your name and your organization in the chat so that we can have a record of that and know that you have joined us. So, as I said, we've got a great interview this morning. We've got Kumar, who is with the Chi-Squared organization, and we're going to get into that. But first of all, I would like to just get to know Jay a little bit more here. We've been chatting for a little while, but Jay, tell us a little bit about your background, where you grew up, what you did as a younger person, and some of those things.
Yeah, absolutely. So I'm actually a North Carolina native. So grew up in Raleigh. I consider myself a native. I was born in India, but moved to Raleigh when I was 1 with my family. And so both my parents were are physicians and work. Both are retired now, but moved to North Carolina from India, grew up in the Raleigh area, went to my undergrad at NC State and was convinced I was going to follow in my parents' footsteps and become a doctor. And then I took biochem and realized, no, I'm not. And very quickly found a passion working with youth and ended up graduating from NC State and spending the next about 10 years working at the YMCA, from starting as a youth counselor, youth director, running summer camps, and then ultimately working in the for new Ys that the YMCA the Triangle would open to help get them up and running. And then in 2015, my mom was cleaning our house and reached over a candle in the prayer room to wipe something down, and her dress caught on fire. And she ended up with full thickness burns from her knees to her neck. and was hospitalized at the UNC Burn Center for 9 months in a medically induced coma, while they had to do skin grafting treatment, pain management. And at that time, my sisters, I have 3 sisters, they're all older than me, lived in New York, New Jersey, and Phoenix. And so I was the only one here. I was, my dad, who is a physician, was a little bit emotionally shaken up by the incident as he saw his wife on fire. And as you can imagine, that could be challenging. And so I was made medical power of attorney and had to figure out how to navigate all of those decisions on the fly. And through that process, realized that there was an opportunity to kind of go back into healthcare and do something a little bit different. So in 2015, went back to school and got my MPH in health policy and administration from UNC to really look at how can we start affecting the system of care and make that a little bit better. And really what stood out to me is we were in one room and there was a family next to us in the room next to us. And my father's a physician, my aunt's a nurse, my brother-in-law is a physician. We were able to navigate the system relatively easier than others just because we knew the system and we had an inside viewpoint. The family next to us did not. And so when we were advocating for our care and certain clinical procedures or certain things, they just went along with whatever they were told. And our mom made it and their father didn't. And it made it very clear to me that we've got to be better about how we engage families in their care and how we do that as a health system collectively. And so that was the focus of my time at UNC in getting my master's, is really how does the health system engage community? And so I left UNC and ended up working for the state, doing disability Medicaid and working on claims for about 2 years before leaving DHHS and moving to NCHA to oversee a new grant they had just received to stand up their entire opioid practice. And so I was helping to design and lead our opioid initiatives for the association. As that role kind of grew, my role evolved with it and was able to take on more responsibility. And over the last 5 years, have really morphed into doing a lot of our strategic planning within our foundation and largely am comfortable being topic agnostic to a certain degree, where I can move in and out and help really shape our strategy for various areas of work, including but not limited to serious illness care. And when the Duke Endowment approached us about partnering with the South Carolina Hospital Association to launch the soon to be renamed Carolina's Health Innovation Institute, we jumped at it and really have for 18 months a pretty thorough planning process to get a sense of how we can work across the state. And then in January launched with some initial areas of focus, serious illness, hospital at home, and then we have a few more in the pipeline that'll be ongoing. And we also just recently hired a second program design person who will work with me, and so she'll be starting next week. So we'll have even more bandwidth to support organizations and partners. So it's a little bit about me, how I got here. That poem I read at our last meeting, it's not just about serious illness care to me. It's kind of back to when my mom was in the hospital, and how do we be careful with each other and know that there's only so much time in which we can do that. And that's kind of my why statement in terms of why I do this work and why I care about it. And so, yeah, David, Catherine, back to you, I guess.
Wow.
Thank
Wow.
you so much for sharing that story of your situation. And so often it happens that we get into a certain profession or a particular area because of personal experiences. And Jay, we had no idea. And it's, we really appreciate you being open and willing to share that. And let me ask, first of all, how is your mother doing today?
She's well. Both her and my father are good. They're living in Cary. There were complications when you're in the hospital that long. Things
Yeah.
change, and at that elderly age too, for both of them, there were additional issues, and so she is limited mobility, and um, and she's a fighter. So this is her second major accident. In '95, when we were kids, we were driving back from DC, and a truck ran us off the road, and our car flipped 4 times down a hill, and she ended up severing her C4 and C5, and they thought she's going to be a quadriplegic, and instead she decided, no, I'm going to walk again, and walked, and had a limited mobility in her right side. So we learned to manage that, but she was working as a lead researcher at DCRI, so Duke Clinical Research Institute, until her accident. And she was like, well, now I get to retire when I want to now. And so she's home and doing well. And she's excited because now she's got all the time to help plan my wedding with my fiance, since she's in her family's in Minnesota. So my mom being down here, I think has been nice. So they're doing well.
Wow, what a story. And so 2 serious illness or serious life-threatening issues. That is just amazing. And you've been there obviously for all of them. And as you said, you were the primary individual there. You had the power of attorney for her. And how did that feel? Tell us just a little bit how that felt, if you don't mind.
No, absolutely. I think it's important to kind of remember that when we try to think about our work, and especially providers, because a lot of times she was, again, in a coma. So you're making decisions for somebody on an assumption. And I'll be very transparent and honest with you all. There were times where it's like, does she want this? And am I doing the right thing? And her advanced care plan didn't account for being in a coma for 6 months. And so it's hard to figure out what is goal concordant care there, and doing the best you can with how well you know the person. And so it's a challenge, but it's it's one I was not happy to, but fortunate enough to be able to support my family with. And it's great now because my sisters have moved back into the area, and so she joked, now all of her grandkids are around her, whereas before they were all over the country. And so kind of figuring out those silver linings after the fact. But when you're having to make complex medical decisions, like, okay, we have to wheel her away to surgery right now to handle this issue or not, do you consent? And you're like, yes or no. And it's very, it can be very challenging or traumatic, but being able to manage that and process that and understand that, you're not the only one in those situations, and having others that you've been able to talk to after the fact to better get a sense of, it's okay to feel vulnerable or feel questioning of did you do the right thing for your mother? I think those are challenging things that as anyone ages and we have to make those decisions, regardless of if it's a traumatic emergent event like a burn event or just the standard aging process we're all going to have to potentially deal with. And so having the supports and having the framework for others to feel confident in that, it's okay. And it's hard, and that's fine. It's okay that it's hard.
Yeah, absolutely.
Jay, you said something I wanted to pick up on. You said that the family next door didn't have the resources or the understandings or the insider baseball, if you will, that you guys did. What can we as insiders do that we're not currently doing that will help close that gap? Because that story, I mean, if you asked any of us, we've seen that family before. So how do we close that gap?
Yeah, that's kind of the question, right? I mean, and that was the question that I had when I went back to get my master's. And It's the question we try to answer every day. I don't have a great answer per se, but I think it starts with, how do we resource the system, or sustain an ability for not just conversations, but a honest back and forth of what are the ways in which your person can receive care, and empowering communities, especially marginalized communities, and communities with low wealth, to be owners of their own health. I think we've got to approach health a little bit differently, as it relates to, serious illness care. The plan that I shared with you guys last week that we're thinking about, it's not innovative. I don't mean that to be like facetious, but it's nothing new. But what is new is that, how do we create a space where the whole family understands the system they're about to navigate, and will appropriately use the resources because they understand the goals of the person in which they're helping to navigate the care for. And so, how do we incentivize that? How do we pay for that? That's kind of the underlying theory of change, I guess, that our serious illness care program within the Institute is trying to understand. And that's why there's that big bar of family caregiver support, and really the care navigator piece. And so, how do we ensure that those families have resources to, or understand the resources at their disposal? I think that's the way we start shifting it. And it starts with ultimately figuring out a way to pay for that type of engagement, because there's time and energy, and that costs something. And so it's not just going to happen because of, people's good intent. We've got to figure out how to make the business case for patient empowerment.
Yeah. I think you've got it, and that's why we're all here. That's why 150 some people have joined this coalition, because we all believe really in our hearts and in our being that is an important thing for us to do. I don't know if I've shared with you, but our Mind My Health platform, that was also paid for by the Duke Endowment, we've said our tagline is "Own your health and plan for care in advance," and you've just said that. And so I think we have a unique opportunity with 4 of our working groups here to be able to do that in unique ways. And then working with you, we're really excited that the Carolinas Health Innovations Institute is going to be coming alongside, or we're coming alongside you, or however you want to say that. We're going to be working together. So that's great.
Yeah. We're coming alongside you guys. You guys are the experts. Like, we're doing this together. I would not how we can help accelerate the good work and kind of lean on the expertise of this group is going to be critical. And similarly, our partners in South Carolina, to ensure that we're able to do this in multiple settings.
Well, we're very excited that we can do this, and just hearing, every time we have one of these Friday Facts, we learn more about somebody like you who has had a unique set of experiences that have influenced how you're doing things. John Toma asks a question here. So we, as you know, we open it up in the last little while of our interview. From your experience as a caregiver, and as in your role that you've had, how can medical providers improve how we engage with and listen to the caregiver? There's a good question for you.
It's a great question. I think, and this group gets it, and it's a start with life, not the clinical work. And by that, we're ultimately, if we're trying to have folks understand a very complex system and go through a very challenging period, it requires a certain level of behavior change, and understanding where they are in their life, understanding their realities, and understanding that it's going to take a little bit of time for folks to be vulnerable authentically. And so that's kind of, as a caregiver, there is so much of the clinical stuff that you're going to get to, and it's inevitable. That piece is inevitable. We're going to have the clinical stuff, but in order for the change to really occur, we've got to start with where people are and meet them where they are. And so how do you create a space as a provider group, or as a health system, or a hospital, or a clinic, for your providers or provider adjacent staff to understand where your patient is? And I think this is another piece, is patient, caregiver, provider. It almost creates a hierarchy. And so how do we bring both of those folks together and change the language, in that the provider is responsible for what the patient wants, and they are really a source of information so that the patient can make the best decision for themselves. How do we build that type of understanding? I think, I see Mary Lou's question in there, and I would say you could probably do that also in terms of our kind of graduate medical education, viewing trainees and viewing folks as really conduits for more accurate decision making, rather than the expert who tells you what to do. That would be kind of it. And then from early basics of how do we incorporate the need for care into college and high school curriculum, I think it's a really interesting question, and something we've got to think about. What do we, I overheard this, I can't take credit for it, but our schools, for the longest time, they've been set up to be factory lines. You go in, you have a set work day, you have an output, and then as long as your output is being met and you meet your quotient, then you advance to the next, you get promoted. Because for the longest time, the American economy was a manufacturing economy. And so our schools were set up to provide people that would thrive in a manufacturing environment. Well, now we've moved into a service economy, but our academic system is still a manufacturing one. So how do we reinvent our academic system to create a new workforce that is in a service economy? And what does that mean? And how would we do that? That's a loaded question. And I think you ask 10 people, you're going to get 11 different answers. So, but at least starting to think about, why is it that over the last 60 years, our public education system, while it is being completely under-resourced, it's been asked to do 800 different things that it was never designed to do. And so if that's the case, the system is giving you the results it's designed to give you. It's not broken. There are no broken systems. They just provide the output that they're designed to provide. So thinking about how we reinvent certain facets of our children's education so that they are better prepared to be part of a service economy, and understanding that service economy is also being a caregiver. That's just not, this other world that we're talking about.
Good insight.
So Jay, I had this light come on when you were talking, and the word that came to my mind when you were describing the imbalance between providers and caregivers and patients. And I'm using that word, you didn't, but the word that came to my mind was equity. And we've been talking a lot about equity in many, many different areas of the world in our life right now. I think that really is what we're talking about here. That is really the definition of health equity, that we're in a situation where we've got imbalance in our system, so that the patient and the family don't enjoy the equity of being on equal footing with their healthcare providers, even though it's really about their life. And so I think that's an interesting challenge. So what's in that space that you talked about when we create that space? What would you like to see closed in there?
I don't think I can answer that question, because it's not just, I think we've got to ask a lot more people about, I'm not a provider, and so got to really understand the realities of provider dynamics and what the pressures they're facing are. And so it really is about realigning incentives and incentivizing that type of engagement. And so, what goes in that space, I'm not sure, but we can't, if we're talking about equity, that means we have to meet both groups. And so we can't just say like whatever the patient wants. There's some realities about being a provider that we have to take into account. And as not being a provider, it's hard for me to say what all goes into that space, but I do think it's about figuring out. Right now, we are not incentivized through payment, through outcomes, through whatever, to create a more two-way communication channel. It's best practice, but it's not standard practice. So how do we move to that? And I think it does start with upstream education. It starts with patient engagement earlier, and also just with us really figuring out what is the public facing messaging. I think that when we think about some of the stuff that we're dealing with, there was an attempt when the Affordable Care Act was started to try to get ahead of some of this work with having advanced care planning conversations and educating folks, but then that was quickly turned into death panels and quickly, for lack of a better term, bastardized for ill intent. And how do we now revisit that and start educating the public as well about these are the things that you have the appropriate opportunity to talk about. These are the things that are in your purview. These are the things that you have responsibility to ask, and doing that from a community standpoint, and then also engaging providers to get a sense of, okay, what are you guys really facing as barriers? What's preventing you? If you could remove one thing, what would it be? How would that change your scope of practice? Who do we need to talk to in order to make that change? Is there regulatory or policy or payment reform that needs to come into considerations? It's all the things the 4 work groups are really trying to unpack. And then how do we then support each other in advancing, little bits of that?
Great points, Jay, and thank you for that. And I'll just mention, I've mentioned it briefly before, but Adam Zolator in his new position, one of his side jobs, if you will, is the, I think, deputy director of AHAC here in North Carolina now, and he's going to be helping to put together some GME around those very things. I want to not miss Karen Appert's, our good friend Karen Appert's point here, and I'll just read it. As a longtime caregiver of a mother with MS and dementia, and we know that we're working with her on a clinical trial. In my experience, the concept of living with, not necessarily dying from, a serious illness changes the dynamics of how both acute and primary care providers approach the patient and the family. We need to figure out how to better coordinate care when patients and caregivers are living their day-to-day lives in the community. And Karen certainly knows that. And I think all of us do, but the experience does inform how we do things. So, and with that, I'm afraid we're going to have to wrap it up. But Jay, this has been very, very helpful for all of us. And thank you for sharing your story and your background. And we look forward to continuing to work with you with the Health Innovations Institute. And man, this is Friday facts are always amazing, and we just never know exactly where they're going to end up. But we know that many other people are going to listen to this as it's recorded. So hope you all have a great weekend, and we'll look forward to seeing you in the not too distant future. Everybody take care. Thanks, Jay.
Have a great weekend. Take care. If anyone needs anything, feel free to email or contact me. I'm happy to answer or have any other discussions.
Wonderful. Thank you.
Mm-hmm.